All right, welcome everybody to the Locum's Tenens break shop. So we have a distinguished panel of a lot of different people. This was a joint presentation put together from a variety of APSA committees. My name is Megan Arnold, and I am representing the Surgical Quality and Safety Committee. I'm going to have the rest of our panelists up here introduce themselves.
I'm Tony DeRoss, and I'm representing the Workforce Committee.
Afif Kulaylat at Penn State, representing the Quality and Safety Committee.
Marcine McVeigh from Arkansas, representing the Practice Committee.
Sabina Siddiqui, also from Arkansas. I'm here as a practitioner of locums and a person who uses locums in her current practice.
I'm Suzanne Yoder, and I'm here as a person who practices locums and per diem work.
And I'm Erica Carlisle from Iowa. I'm the chair of the Ethics Committee.
So in terms of disclosures, as you've heard, some of our panelists currently work or have previously worked with locums brokers to fulfill assignments. And then Dr. Siddiqui also has an additional disclosure listed here. We have a couple of objectives. What we're going to do is I'm going to do a little bit of a background, and then we're going to work through 3 different cases. The first one is fairly short, and then cases 2 and 3 are a little bit more involved, and there's going to be some opportunity to have some discussion and comments from you all after cases 2 and 3. To start, though, we'd like to get some sense of what your experience is with locum. So if you could please use your Whova app and answer this polling question about exposure or experience that you have with locums within the last 12 months. And then Dr. Martin later on in the talk is going to give us the results. We won't have these right away. Keep going. All right. So if we think back about the history of medicine, the idea of a locums tenens has been around for a long time. So this is perhaps one of the earliest mentions of it, perhaps where the term was coined, from the late 1800s in a British medical journal, where medical men thinking of much needed holidays are deterred by that idea because they can't find temporary substitutes. And yet there are young providers who would be happy to go and fill in. How do we get these two together? We propose this idea of a locum tenens. So despite this very early mention and the continued use of this idea into today, there is a pretty significant paucity of data about how much it's being used, and that is particularly true in our subspecialty. One way that we can start to get some data, this is from a report in 2024 from CHG Healthcare, which is a parent company of other smaller locums companies, which you can see listed there. This was just a survey of how many people, how many physicians in the United States are doing locums work. Now, this is not surgeon specific. This is any medical provider. And what you can see from 2015 up to 2023 is that the absolute numbers have increased almost twofold. And the absolute percentage of physicians working in a locums type practice is about 7% of the total physician population in the United States. If we want to get some information about what does this look like in pediatric surgery, so these are some older data. So this is a paper published by Dan Nakamura back in 2015. This was a survey of APSA membership, so a pretty small subset of surgeons within the US, but the most specific data we have about pediatric surgeons. So 1 in 5 pediatric surgeons at that time did locums work. 1 in 4 pediatric surgery practices used locums to some degree, but 2 out of 3 respondents felt that perhaps locums did not provide the same level of care as the permanent surgeons in that practice. Why do healthcare organizations hire locums? Again, this is data from that 2024 CHG report. So often used to scale medical services. This is a workforce that is easy on, easy off. So if you have a short temporary need for more work, you can bring people in, and then when that need doesn't exist anymore, then you don't hire them to continue on. So to meet increased patient demand or to supplement staff during peak periods. And if you're transitioning your organizational model, it may be that you need a little extra help, and locums can fill that gap as well. Locums are often used to relieve pressure on medical staff. I think we've all seen that. So if you're in a very small practice, perhaps a practice of one, if you want to take a vacation, what do? Well, you can bring a locums in, and they can cover your practice while you are away. You can use locums to provide family leave for a variety of reasons. And if you need to help mitigate burnout or reduce staff workload, you can bring in another person on a temporary basis, which can be days, weeks, months. Just like there are lots of reasons that healthcare organizations use locums, there are lots of reasons that physicians start to do locums work. Again, this is physicians, not just surgeons and not just pediatric surgeons. Interestingly, the highest percentage response answers were to supplement income or because the salary was appealing, but also very high on that list is the ability to control your own schedule. You can decide how much you want to work, when you want to work, and to a certain extent, where you want to work. Some people use it as a bridge to times in their career. So is it something that you're doing as a bridge between training levels, or is it a bridge to retirement? Maybe you don't want to work that same academic job that you've had for X number of years, but you're not ready to completely walk away. This is something that you might be able to do for some amount of time, bridging the gap between what had been your full-time career and your retirement. To find a practice that better works for you, to avoid burnout and overwork. So lots of different reasons that people might choose to pursue a locums job.
Okay. Sorry, so I just wanted to go ahead and give the answers to the first question. So at least amongst this group, about 20% of us have done locums in the last 12 months. About 30% of us work in a practice that has utilized locums, which then leaves about 40% which did not fall under either of those categories. But just as a rough idea of who's in the audience.
Now, as we move into our cases, I'm going to turn this over to Tony DeRoss.
Thanks, Megan. This first case example describes a group of pediatric surgeons who have 5 in their group. They provide coverage for a quaternary care system. They cover both inpatient and emergency surgeries at 3 hospitals in the region. They do about 1,200 cases per year together. And 2 surgeons leave that group within about a 12-month period. So 2 surgeons were hired in a locum tenens capacity. They covered 1 week of daytime call and 1 weekend of call every 5 weeks, so it was about 1 in 5 for each of the surgeons total, including the locums in the group. The locums surgeons didn't cover any outpatient clinics, but they did perform index cases during their assignments, but the long-term follow-up for those patients who had index cases were done by the 3 full-time pediatric surgeons. And this paradigm was used for over a year until the group was able to hire 2 more permanent surgeons to help cover the group. And we didn't want to spend a long time on this case only because we think that everyone would pretty much agree this is a very mutually beneficial use of locums coverage. It helped to bridge a gap in surgical coverage for this group and allowed patient care to continue uninterrupted and allowed the group to survive while it rebuilt itself. If there are any questions, we can talk about them later. I'm going to turn it over to Sarah Walker from the Wellness Committee.
So we're going to dive a little bit deeper into the scenarios now and start thinking about a practice in which a locum tenens is covering on a locums assignment. She's now covering 2 different hospitals in a large metropolitan area, a children's hospital, which is freestanding with all the resources, and a community hospital. She gets a new consult at the community hospital for a toddler with a renal mass. The pediatric oncologists that do cover this facility mainly treat hematologic malignancies. She assesses the situation and she decides that she wants to transfer the patient to the Children's Hospital for for surgery and oncology care. So, our next poll, what would you do? Do you think about talking about it with the group that covers in the area? Hey, what do you guys normally do? Or explain to all parties, in your professional opinion, we need to transfer this patient. You perform the nephrectomy at the community hospital, or do you ask the locums broker to intervene and kind of take the discussion from Group B? Let's see. We'll give everybody a chance to respond. Let's see. Good news is I think I can see most of it on my phone. All right, with about 40 respondents, we have a fair number of people that will talk to the group that goes ahead and covers, so our option A. And then 28 out of 46 would explain to all parties that they believe they need to go ahead and take a transfer. All right. And then let's change the scenario up a little bit. Let's say the Children's Hospital with the appropriate subspecialty coverage are now covering that community hospital, which are several hours away instead of within the same city. Does this affect your decision? Oh, I guess I finished the question. All right. Answers are coming in. We're going to have a few more discussion questions, so if anybody's starting to feel moved by this, we're going to have some room at the microphones. And so actually, this case is making us, for the most part, 4 people wanted to keep the patient in the local to serve the child in the community, but more were wanting to transfer because I still think it's the right thing to do, answer C, and because B, backup's not close. So, all right. So the next thing that we want to think about is in this discussion, when we're thinking about locums, who are our stakeholders? Who are we, thinking about? Are we thinking about the group that we're covering? Are we worried, the patients and their families, the people that work at the hospitals and the ORs? And then when you think about those stakeholders, how do you decide whose interest needs to be, have the greatest weight? What do you do about quality and safety concerns, liability concerns, ethical concerns? Because these are all things that are going to come up. And when we started talking about this as a group, as our committee, one of the things we wanted people to think about was to actually think about this stuff, before, especially for someone who hasn't gone into locums, which I think only about half the people in the audience have not, is to have this in your mind. So does anybody have any ideas or comments on the situation and encountered the same situation? Nope. How about on our panel?
I can speak on this scenario for sure. I love this diagram because I think it's what we all need to focus on is the patient. And in my opinion, this particular case, whether that patient is being treated by a locums provider or just a surgeon who happens to also cover that community hospital on a regular basis, if the patient is going to be better served by being at a facility that offers all the things necessary to treat their tumor, they should be at that facility. And that's my personal opinion. So when I am in a locum situation where I feel like I have the capability to perform an operation, but does the institution have the capability to treat that patient appropriately, I, without question, will transfer a patient if there is not institutional capability to take care of that patient.
To add a little bit of nuance to that, though, is we all kind of grow up in a practice and learning certain practice patterns. And when you go to a locum's place, it's really important to do your investigation as to what the practice patterns there are and what the resources are, and to understand the kind of variations that you can safely adhere to and not try to disrupt too much the culture that you're walking into. So to approach it with a little bit of humility and try to understand what the practice patterns are, why they are that way, and what support structures you have to provide the safest care.
Yeah, and I think ethically, I think this case sets a really nice example of some of the tension between balancing our responsibility to ensure access with our sort of fiduciary responsibility to ensure quality and the most beneficent care that we can. So I think that that's a really clear ethical tension in this case.
I just wanted to bring it up almost as a matter of question for those with experience in this situation. So, you know, if you're working locums, you're almost kind of an extension of the team or the group that you're joining. And so in that question, one of the answer choices was to defer to the judgment of the group. And I'm just curious if in that situation, the group normally would have done the resection and then, let's say, transferred out to another institution for subsequent chemo and everything else. How do you think that should be handled?
Well, so there's a lot more, going back to the term nuance to this. My presumption, if I'm joining or helping a practice of established surgeons who are going to work and provide that care at that institution, I would like to believe that they've put the thought into it. And it's not uncommon in places that I've practiced locums that the primary team at the university hospital is not just the surgeons coming out, but it is also the oncologists coming out. So they also have extension of services into these spaces, and they have ways of balancing that. But that would just merit further discussion. Make sure you balance what you feel is safe and for the child, as well as trying to work within the practice patterns of that practice.
I mean, I think you've got to be a little bit more specific with the scenario. So if I am the one surgeon in town covering both of those facilities and no one from that practice that I'm covering is currently there, for me to kind of call and be like, hey, I've got this, I think that presents a little bit different scenario than, like, sometimes you'll have one surgeon at one institution and another surgeon at another institution. If you have the ability as a locums to consult with someone who's also on at the same time, it changes the dynamic a little bit than if you are just out there by yourself. But yeah, I mean, when there's an opportunity to speak with someone who you are covering for, then yeah, I'm always into collaborating with them and discussing with them what they think should be the best care.
You could probably hear me. So oftentimes I find that collaborating with other professionals, other physicians, other APPs, the patient is at the center. What happens if you start to get institutional pushback about transferring a patient?
I've been very fortunate in my experiences working locums that I have never received institutional feedback. And I have transferred patients out that other members of the medical care team, specifically NICU doctors, or other professionals in the hospital, felt that they actually could take care of. But I have transferred patients out, not often, but when I have stood up for the patients, I have not received significant institutional pushback, and I've been invited to work at those places repeatedly. So
I have to say I have the same situation, but often for the practices that I've helped out, I've had a conversation with the chief of service, the person that I'm coming in, as well as the CMO, and we've been very proactive about setting kind of guidelines and rules and what I'm comfortable with. For example, when I first started doing locums in Arkansas, before I took the permanent job there, they were very clear that I would be doing torsion. And while I knew the principles of testicular torsion, I had never practiced that alone on my own. And I was very forthright in feeling uncomfortable about that. And we created a plan together in which I would learn the skill set so that I was comfortable managing that particular patient set.
So I have a question for you then. There's quite a few hospitals out there that are just keeping their NICU designations. They might not have a lot of their other services. They just want the NICU, right? As Dr. Farmer said, it's the NICU bubble. It prints money for the hospital. We know all that. How do you feel about hospitals just literally stringing together a series of locums just to do cases and then leave? Like you get a kid with gastroschisis, you've got another hospital with a practicing group with the other resources 2 miles away. How do you feel about that?
Yep.
We're going to go a little bit out of order. So we're going to present the third case real quickly because we have a couple of polling questions.
Yes.
But then we really want to make this an open discussion. People that have used locums, people that do locums, challenges.
We'll answer that question.
Yeah.
Just give us a second.
And then we got Adi Fahey, who's coming to us from the University of Penn State. Wow, I was like, it's all in the Northeast for me, from our practice committee. And also at all of your stations, there is a QR code for the paper that she just first authored on locum tenens.
Thank you. Great. So the reason that I and Abigail suggested that we kind of go ahead is because this is kind of addresses your question in particular. So this scenario, as you can see in kind of outlined here, rural hospital trying to maintain its NICU and had previously employed 2 full-time pediatric surgeons, but now it's trying to maintain coverage with just locums providers. So cover in-house consults and calls, but those cases are mainly NICU and ED cases, again, to maintain an open NICU and to likely maintain trauma coverage and trauma certification potentially. And so we realize that this provides a lot more controversy and a lot more nuance to the discussions about it. And since it kind of did come to your question, it seemed like a timely opportunity to move to this one.
Should I comment now?
Great. So I can see, sorry, I didn't read out the question for you guys, but essentially a NICU baby with a low anorectal malformation with a perineal fistula. And you have a range of options, and I can see some poll responses coming in now. It's question 4 in the Hoover poll if you've just joined us.
So the answers are,
If you want to go ahead and answer the answers to the question are still coming in. So if you just want to go ahead and comment, and then we can let people respond.
Perfect.
I'm going to comment on the question that was.
So for those who came in late, it's the Hoover app. So that if you go to the session, you should be able to click the link for the questions.
But while we're waiting, if somebody did want to address how do people feel about a practice that's entirely staffed by locum coverage to maintain a NICU or trauma, that would be wonderful.
I'm just going to state some facts, and then I will let people interpret how they feel about this. I have worked in a locum situation where I was covering a surgeon who then left the practice, and that practice is currently covered by a rotating crew of locums. When I first started doing locum tenens, I said that I would never work in a place that did not have a full-time surgeon that I was covering or that I could sign off for. This issue of having these places that have NICUs that are rotating locums coverage is becoming more of an issue. This practice is actively trying to hire and has been actively trying to hire. They've offered me the job multiple times. I mean, they're trying to find someone to fill that job. And they have a robust crew of people that rotate through who I am comfortable signing off to and working with. So when I started doing locums, I said I would never do it because I really was concerned about long-term care and follow-up for these patients. The current system, I'm trying to help them bridge to finding the people that they need to find. And I do feel like we are providing a good service for the patients there. They still have a robust NICU and a robust peds anesthesia program, and they have other facilities that make their program a nice place to work and a good place to take care of children. They just can't find someone to take that job. And I think for me, that's less of a question about locums and more of a question about practice of pediatric surgery in the United States and training people for the jobs that are out there. But, so those are my comments.
If I could just comment, Ronan Aurelius, Kalispell, Montana. And I think, as you point out, I think it's probably very institution dependent, right? But I think as a surgeon who practices in a place where there is another hospital fairly close by that is doing that, like keeping their NICU alive with rotating locums, it is hard to then watch those families and those patients come to us down the line because there's no one long-term doing continuity of care. And those families saying, oh my gosh, if we had known a 2-hour drive away was a robust team that would take care of us for 18 years of life, we would have just come here in the first place. And so I think you have to take all of those things into account of like really what is the best thing for the patient and the family here. Do you, if it's really just that you're missing the surgeon, but you have everybody else that can provide that support and long-term ongoing continuity of care, that's something. But I think most of the time you're probably missing more pieces than that. And if it's not I think the families at least need to be given the option, I guess is the thing. I'm not sure that at all of these institutions, the families are given the full picture of like the surgeon that's treating you today may be an excellent surgeon, but they will not be here next week. And you don't know when you're going to see them again. And so I think transparency with the families for that is really important because I don't think that's happening.
That's a really nice point. And again, it kind of makes the patient and the patient's family very central to the discussion.
Stuart Lacey. I'm here at Banner in Phoenix. And Susan's one of our locums per diems, and she is spectacular. So several things. Number one, in your series of answers here, one of the things I do not see is the option of doing the anaplasty and then having the patient followed up with somebody else who's in this rotating group. So the accompanying question to why isn't that option there is the question to Susan, in that group that you're talking about that you work with some, is there an outpatient follow-up available by whoever is the rotating pediatric surgeon? So obviously the answer to this question for most of us in the audience, I would think, is going to be significantly different for this low anal rectal malformation versus if we had a higher malformation, which goes back to the prior commentator, because I know for me the answer would be a little bit different for these two different situations, and the answer I would put isn't on the board.
Fair. Perfect.
So I guess, So I guess that brings up another question, and maybe people in the audience can say their experience. So some of these hospitals, either that you work at or know of, are those surgeons that are being hired for locums to keep a NICU up and running, do they even have an outpatient clinic for the locum surgeons? Or are they just there to deal with inpatient issues? Right.
Yeah, and so for this scenario, that was kind of why we made it that they did not do outpatient follow-up, to just slightly force the issue and force the conversation, and just to kind of feedback the results from the group, which are not quite as cut and dry as you might imagine. About half of the people did think that teaching the NICU staff to do dilations and then referring to the nearest full-time ped surgery practice made sense. And then 15, so about a quarter, thought performing the anorectoplasty and referring the family to the closest full-time ped surgery practice for follow-up would make sense, with the other quarter essentially deciding to just transfer the patient to the nearest facility up front. Dr. Rika.
Yes. Can you hear me? Sorry. I usually don't talk of these things. So, and I appreciate, I had an opportunity to review some of the manuscript before, so that was tremendous. I think the one thing that I appreciate you guys bringing up is the complexity of this situation. We have a NICU that's probably an hour and a half away from us that we are covering because they can't hire a surgeon. So we're not covering it by locums, we just cover it. And the real issue is if they shut that NICU down, where do those children go? We're talking about the one patient here, but what about every other child in a bassinet there? We can't absorb another 40 to 50 patients in our NICU. And so I think the complexity of care for all of those children becomes a big discussion that we need to recognize that it's not just a surgical patient in front of us. Sometimes when you're talking about a NICU stringing along care for the patients, it's all of the feeders, growers, and other children that receive that care that you're a part of, but maybe may not see directly. So I think that's also a part of this locums discussion, to your point, which was great. It's care in America and how we're providing care and how are we training people and what are we doing to get that care better. So thanks, guys.
Super. Great. So then to move on to the next question, and if you were one of those peds surgeons providing locums coverage, again, without being able to provide follow-up and in a kind of rotating cadre of locums, and you had a type 3 esophageal atresia with tracheoesophageal fistula, which of these options would seem the most reasonable to you? So it's great to see this session so well attended, and I think it really does speak to the challenge that we're having and to some of the nuance in providing access while, prioritizing patient care. So this seemed much more straightforward for people. I think 39 out of the 40 people or 42 who've responded just wanted to transfer that baby to a facility with a NICU that is full-time pediatric surgeons available and for follow-up. Wonderful. Thanks. And I'll hand over back to Megan and continue discussions.
So we've kind of touched on all of these topics. So what are some of the potential issues when the only coverage in a community is provided by locums? What are practical issues to practicing in such situations? Are there liability and quality concerns? We've talked about that a little bit for the surgeon, for the institution, and then the ethical concerns, both for the surgeons as well as for the family and the patient. And what are ways to mitigate some of these concerns? I don't know if there are any other comments from the audience, any other situations that people want to talk about. Please, come on up.
Hi, Jaya from Phoenix as well. I have a question for, I guess, the whole panel, but it's about disclosure to families on operations that you're going to do that's going to need something beyond just a post-operative visit. So any of these procedures, what is your practice and what do you think is the right thing to do? You're obviously qualified to do all these operations. And at the same time, I understand that when we guide these parents through such a difficult thing, to introduce doubt or concern that you may not be there later on is something that, it's a tricky thing to navigate, right? You want to provide reassurance. And so how do you navigate that in terms of disclosure?
That is why this guy is my brother in practice.
So I'm very forthright with my families, whether it's in my everyday practice or when I was doing locums. And, we both mentioned the fact that when we met families as the locums providers, we were very clear that we were there as a short-term covering surgeon. And then even in my practice, I'm in Northwest Arkansas, so we don't have all the bells and whistles that Little Rock has. So when I have conversation with my families, I'm very forthright as to what resources we have, what our options are, in what situations we would transfer. And then I let them actually have a vote also in terms of what it means to them to travel 3 hours south and have to be down in Little Rock for the week or so that they would need the care. And we kind of do it like that. One of my worked out really awesome scenarios when I was doing locums was, I had a child who came in with a pancreatic transection on a Saturday night. It was a situation where the local surgeons were covering at the community hospital. I was covering at the academic hospital. I called that person in. We did the case together, knowing that the child was going to need long-term follow-up. And so we did the case together, and the child was able to get the care that they needed, even with the locums provider, and also have long-term follow-up with the surgeon who was also there for part of the case.
I also disclose that I am not going to be there. I tell the families exactly how long I'm going to be in town and when I'm coming back and who is coming after me and what their follow-up would be. I mean, in all honesty, a lot of these kids that we take care of in these NICUs are preemie babies who need a drain right then. And, you explain all the long-term repercussions and you explain that this is going to require long-term surgical follow-up and that surgical follow-up will be available.
Ramin Jamshidi from Phoenix. Can I ask for a poll by show of hands out of curiosity and then offer a comment? So for those in the room who do or have done locums, do you routinely tell people you are a locums provider and not there permanently. And without making it a judgment thing, there's good and bad. The bad is maybe they lose confidence or whatever. And who does not? Is there anybody who routinely does not because you think they may lose confidence or erode them? So the comments from Dr. Bay and Dr. Norelius are exactly why he is my brother in my primary practice here in Phoenix, and she is my sister in our second home in Kalispell, where I help out and do locums. Because I, like the people who raise their hands, think that's very important. And it's really not that far off from most of us are not 24/7, 365 surgeons, right? That's a very rare model now. So is that necessarily different than J.O.'s on call last night and does some emergent, laparotomy, big bowel resection, multiple redo, loss of bowel length. And he's gone. He's got a family commitment. He's on vacation this week and he's gone. And he says to them, my partner Ramin's coming on. He's going to be here, as are my other partners. That's where I think the biggest distinction here is whether it's a system that's set up for a locums to participate in a rotating role in a full service entity. I think that's the distinction between somewhere, well, we've got somebody who we can call for emergencies, and there's no clinic, and there's no continuity, and there's no mechanism for that. Those are my thoughts.
I mean, every place I work, I either have a clinic or I have partners that I work with that have clinics. Like I don't operate at a place that will not provide any outpatient surgical follow-up. Like that doesn't.
The comment was, don't discount that either for places that have nothing. And I think there's a comment earlier, I forgot, Tony, did you say that about somewhere that couldn't absorb the volume somewhere else? So there is some stopgap there, but that may make the difference between these kind of cases, right? You can take care of the perfs and the gastroschises and so forth there, but maybe you don't absorb the esophageal atresia or the anorectal malformation or the oncology patient.
I'm going to just switch gears a little bit and just say from sort of an institution and colleague point of view of someone who uses locums and needs like weekend coverage for locums, I think perhaps a lot of surgeons are not aware that when you go through a locums company, you sort of become an indentured servant, I would say, to that company from the hospital's point of view. So I would just say as a colleague, if you are and it really depends on what you're interested in doing. Like if you want to go and see lots of different opportunities and work at lots of different places, locums companies are probably great. But if you have one or two geographical locations that you're interested in, maybe, hey, I want to go try that out, or they have a job posting, maybe that's where I want to go work. Call the hospital directly. Get on a PRN staffing model with them. It is so much more financially beneficial for the hospital for you to do that, and thus for you as well. And then if you're with the locums company and you then want to get hired onto that position that they are offering, there is a huge buyout to buy you out of that locums company contract for the hospital, which I have seen contracts fall apart for surgeons because the hospital doesn't want to pay that buyout. So just things to consider, and just talk to folks that kind of know the system. The locums company are not your only option.
I think we're over time, but I'll be brief. I'll try to be brief. Just maybe end with a dimension that we haven't really touched on, because it's come up in many of these multiple choice questions, is the perception or the perspective of the receiving surgeon. You've had many options where you would do it and then send it to a surgeon in town or a group in town who will take care of this patient. So I practiced in Southern California for many, many years, and I would get these patients not from locums, but from adult surgeons who have contracts with certain Medicaid, HMOs, et cetera, and would operate on these children as young as 2 for appendicitis, huge incisions, and then transfer them to our children's hospital. And the question I would always pose is, why did you not transfer them before? Because the kid needed the surgery. So of course, if it's a life-threatening issue or something like that, there's no issue. But which surgeon wants another surgeon to take care of something critical that is not life-threatening, like an esophageal atresia, and then send it to them and say, okay, now you take care of the post-op course? I think that's a really easy way to make a surgeon really upset, and it just speaks to the collegiality and professionalism that we also need to exert.
We actually have about 5 more minutes, so we can keep having a little bit of discussion.
One question I had was, and I know how I've handled this in the past. I did a fair amount of locums, and I think it ties into the discussion of the child and what cases you're willing to do. How involved have you guys been, or what would your recommendations be for quality improvement for being involved in M&M conferences, following up on patients? I mean, as a surgeon that used to do that, I've called patients that I've operated on in other states, and they had an abscess, had to be readmitted, check on them, and things like that. So I think that's a big part of being a locum surgeon. How do you guys address that, and what are your recommendations for people looking to do that?
Yeah, I definitely am one of those people that logs into my computer way too much and checks on patients way too much. That's actually not true. It's never too much, right? I do follow up with my patients, and I definitely keep track of the ones, they're those ones that stick in your head and that you worry about, and I make sure that things are going well, touch base with the people that I'm handing off to, talk to them afterwards. Most of the places that I work in, I participate in some of their conferences, but mostly they're like trauma QI conferences.
Yeah, so for all of my locums gigs, same thing, like part of my sign out is, I XLAP this child on, Saturday. Will you shoot me an update on how the child's doing and when they're ready to go home or something like that? And invariably people will let you know how the patients are doing. And then every place I've worked, I've participated in their M&M at the very least.
So I was just going to comment on, I was just going to comment on the institutional resistance to transfers. So I've definitely faced some of that. And in one of the locations that I do essentially a locums coverage, it's mostly a group from the academic hospital in Milwaukee that covers, and what's been very nice is being able to reach out to that group and kind of get a consensus so that it's not just me saying to the institution, I don't think this is best for this baby, but at least having a group of pediatric surgeons saying we all think that this is best for that infant. And then I've also had institutional resistance where I've been the sole provider at a hospital. So as a fresh grad pediatric surgeon by myself and having a local group in town and local children's hospitals and having to have those discussions with the institution saying, I don't feel like this is best, but I think that's very challenging as somebody who's especially junior, having those discussions with the institution to say, is this really best for this infant? So, and any insight into how to have those conversations would be great.
Yeah, I mean, I can say that when I had a full-time job with a full-time practice, I also worked in community hospitals where there was pushback when I didn't feel comfortable doing certain things in those hospitals. And again, I think that's more of a problem within our system globally. And I think I feel fortunate that I haven't run into it during my locums tenure. Sure.
Ian Mitchell from UT San Antonio. I had two comments. One was there was one reason for doing locums, which hopefully is going to go away, which is writing out your non-compete. And so the second comment that I have is I think that this discussion also bleeds into a lot bigger issues with our practice, in that a lot of what we've discussed is what are you doing for the emergent thing, or what are you doing for the baby, and we need to make decisions about lifelong care. I think those are really, really important when you're at an institution that's the only place for pick a number of miles around. There's a whole different institutional pushback problem, which I actually saw more when I was employed than when I was doing locums, when we're talking about hospitals that are near, within several miles, excellent institutions that could easily take care of this child. And then you're also getting pushback. So I feel like from a locum standpoint, I found more institutional pushback, far more from places that were near a place that could be transferred rather than those that were further away.
Yeah, that's an excellent point. And we have a minute left, so I'm going to wrap up really quick, and then hopefully we can all have some more conversation afterwards. So as this discussion has demonstrated, there's a wide variety of situations encountered in diverse practice settings, which reinforces, again, the word nuance and the complexities of site and region-specific resources, policies, and environments. So there's clearly no one-size-fits-all approach, but there can be some foundational tools that can be used across all settings to help provide a fulfilling practice for the pediatric surgeon, a streamlined solution for the host organization, and most importantly, a safe environment for the patient, because that's our guiding light. Specifically, the locum surgeon should ask for an extensive list of hospital resources and specialties, clear expectations for their practice, and local contacts, both administrative and clinical, that can help them navigate some of these environments. And the host organization or practice group should provide clinical care pathways, clear transferred criteria and agreements between hospitals, and then someone to provide continuity. To that end, the practice committee would like to present this product. It's endorsed by the APSA Board of Governors, containing practice guidelines that should be foundational, while also recognizing a lot of the challenges associated with differing settings. So this code will take you to the JPS site where you can log in and access the preprint draft. So we hope this will be an effective resource for pediatric surgeons and surgical practices to administer safe, high-quality care to patients in these settings, and also to utilize to advocate for the necessary resources to deliver such care. And we look forward to this being part of additional discussions amongst the committees and amongst the membership, as well as to inform the APSA PedSurg Save project. So thank you all for your attendance.